class. Okay, so welcome. First question is, what are your expectations for this course? All of these are anonymous, by the way, so you can be completely honest. So if you're somebody that wants to work in pediatrics, you just want to learn things that you can apply to your own family, your own kids, cousins, nephews, nieces, grandkids, you're just here to have fun, or you absolutely hate peds. Okay, so we got a little bit of everything, but most everybody's like in the adult realm. Oh, now we're starting to shift a little bit of everything. So I will tell you that pediatrics is going to build off of your adult med-surg knowledge. So a lot of common conditions in pediatrics are the same as in adults. They just might look a little bit differently, present a little bit differently. Wonderful. So we've got a good mix of people. Very nice. Okay, we are going to go ahead and move forward. What are things that you already know about kids? What knowledge do you already have? And you can just type in your response. They talk back and don't listen. They are difficult sometimes. Yes, that is very true. We have to be very creative in our approach to pediatric patients. What else do we know? Weight-based dosages. They're a lot more resilient. Yep, lots of resilience. Not much ahead of time. Okay, we will fix that. Yes, they are a lot more perceptive than we give them credit for. Parents can be challenging. We don't just deal with our patient. We have to deal with the parents as well. Yep, their immune systems are underdeveloped. Sweet and sour, yep. Depending on whether or not you're doing what they want to do, can dictate their mood a lot of times. Yep. Parents have a lot of anxiety when it comes to their kids. Nobody likes their kid being sick and feeling helpless. So parents are definitely anxious when we meet them. They do tend to heal quicker just because they want to get back to playing. They're not going to be lazy. They do have a short attention span. So we have to be very aware of that when we're presenting information. Lots of imagination. Good job, guys. Those are all great. So we are going to start with growth and development. There is a lot of information in here, and it's very difficult information. I will tell you now that the theorists make up a large portion of your quizzes and your first 2 exams. So whatever you need to do to keep them straight and understand what is going on with them will help you do wonders with your first 2 exams. A word of warning, the first exam is very heavy on theory, and students often don't do well. I'm just going to be honest. It's really difficult to keep them straight. So please, please, please attend our exam reviews. We've tried to put together as many resources as we can to help you keep these guys straight, but it is very difficult. So if you are somebody that struggles with theory, then please reach out to me ahead of time so that we can get you ready for the first exam. Here are your objectives. So we're going to have vocabulary words. We're going to talk about our nursing implications for growth and development, the differences between growth, development, and maturation. Those are all different words. And then looking at growth charts. So we have growth, and that's going to talk about things like our height and weight. It's going to be a measurable outcome. The process of development is going to be the mastery of a skill that allows for the infant or the child to progress to the next skill. So we have to learn to walk before we can learn to run. That is going to be development. We have physical aspects of these. So like we talked about height and weight, those are going to be growth measures. Then we have developmental measures that are physical, like our motor skills. So for our social development, we're looking at things like sharing, developing friendships, following rules. Our emotional development, we're smiling, we're self-soothing, we're able to identify our feelings. And then for intellectual, we're looking at the child's vocabulary. Are they able to count? What their attention span is? If they're able to consider multiple points of views, that's all going to tell us where we're at with our development. These are some milestones that we expect between the ages of 1 to 5. Those are going to be important for you as you're assessing your patients. So it's important to know your milestones so that we can assess for delays, which might indicate an issue with nutrition. There might be some issues with parenting and parent education or knowledge that we have to address. So these milestones and the lack of meeting them are going to tell us a lot about the child, even when we just get a snapshot of them. So here's more for milestones in our 2.5 to 5-year-olds. You guys can refer to those as you're studying. Our kids are not mini adults. They have their own growth patterns, their own development patterns. So their plan of care is going to be very different than the plan of care for an adult. We need to be able to recognize the developmental and growth delays to help formulate our plan of care and also provide an opportunity for early intervention and prevent further developmental delays. So being in tune to what those are is really going to help us get the kids the resources that they need. So what are some of the things that make infants and children different from adults?
Infants are needy.
Yep.
They need to be taken care of pretty much.
Yeah, they require total care. They can't do anything for themselves. Yep, that makes them very different from adults. What else?
Sometimes the method of treatment of what they might have, we might not treat them the same way we'd treat an adult as far as
Right.
medication.
Yep, medications might be different. The therapies that we use might be different. So there's a lot of differences that we have to consider. What about when we're looking at the family? With adults, we're taking care of that adult patient typically. Sometimes we might have a spouse or a significant other that might be present, but our main focus is on that adult. Whereas with pediatrics, our focus is on the entire family unit because it all impacts the child's overall health. So those are just some quick differences. We'll talk a lot more as we go. We do a lot of data collection. So when we're looking at the whole nursing process, our whole ADPI nursing process, it applies to growth and development too. So we're going to collect data. We're going to do height and weight, either on a length board, have them standing. They might be on a bed scale, or we might be able to have them step on a scale for an older child. Does anyone know what the purpose of our growth charts are?
To see how good they're growing, what percentile they're in.
Mm-hmm. Yep. So we're looking for that overall trend in their growth. So not everybody grows at the same rate, develops at the same rate. So we want to be able to look at them over time to be able to see that steady progression in their growth. So it gives us a standard baseline to assess a child. What are some of the developmental milestones that we're looking for in our infants?
Being able to like roll over from front to back,
Yep.
hold their bottle, things like that.
Mm-hmm. Absolutely. How do we find out about these developmental milestones?
For their parents, I mean, when they come in for checkups and stuff, you're asking if they're holding their head up yet or different things that they're doing.
Yeah, absolutely. We can ask the parents. The other thing that we can do with older children is we can play with them. And we use play as a way to determine where they are in their development. So being able to throw a ball, being able to stack blocks, we can tell a lot in their development through play. When we're looking at nursing diagnoses, we're going to look at things like breastfeeding, whether it's effective or ineffective. Is it a problem with mom's milk supply, or is it a problem with the baby's suck? There's lots of things that we can look at when we're doing these nursing diagnoses. We're going to look at caregiver role strain related to inexperience, something like a first-time parent. They don't know what they don't know. So a lot of times first-time parents have that extra little bit of role strain because they aren't necessarily familiar with all of the things that we expect of their child. We can also look at things like family coping, especially when we have a medical diagnosis. So a chronic condition can cause coping issues. And then when we're evaluating, we are going to be looking for their growth, their development, meeting those milestones, staying on their growth chart, and providing that anticipatory guidance for parents, helping them know what to expect, what they can do to engage with their child. Here are your key terms for development. So remember, we said development, growth, and maturation are different things. So these terms are going to be beneficial for the healthcare provider to assess because they're going to give us an objective assessment of the child's status. So an example of a toddler having maturation is going to be exercising their independence, learning those fine and gross motor skills, and gaining control over their body. For a preschooler, they're going to be focused on things like naming colors, showing affection, being able to hop on one foot. So you can see how each age group has their own set of milestones that we're looking for. And we have different stages of growth and development, depending on their age. Some important things to remember are neonate is going to be a child that is between birth and 4 weeks of age. And then when we're talking about infants, we're referring to anyone that's 4 weeks of age to a year. So those terms are different, cannot be interchanged. Two other things that we need to look at are cephalocaudal development. So that is development that proceeds from head to toe. So we learn how to pick up our head and control our head before we're able to sit upright and move our whole chest. That is cephalocaudal development. Proximodistal development means that we develop from the midline out to the periphery. So I like to tell people you can do big arm circles before you can pick up something fine with your fingertips. So you can do big movements before you can have control and dexterity over things in your periphery. So your fingers working. Does that make sense? You guys understand those two? Okay. Our growth charts. So we are going to measure our children at every doctor's appointment and ER visit. We are going to use separate growth charts for boys and girls because they grow very differently. So this is going to be a growth chart for a boy. And I'm going to ask you to, I'm going to give you a scenario and ask you to put a pin on where you think this child is on the growth chart. So if we have an 18-month-old boy that weighs 27 pounds, where would they be on the growth chart? And you guys can drop a pin on the image where you think they would be. And once you get your pin dropped, Are they under or overweight? Based on the growth chart.
Can you repeat it again? I'm sorry.
18 months and 27 pounds. Hush, do. Sorry, guys, I've got 3 dogs. They tend to make appearances randomly throughout class. Okay, I'm gonna put the correct answer up here. So here we have our 18-month line that's going from top to bottom. And then 27 pounds is gonna be right about here going across on our weight scale. So this general area is where this child would fall on the growth chart. So they are between the 50 and 75th percentile. So would that make them under, over, or just right for weight?
A little over, isn't it? 75 percentile.
They're kind of hanging in the middle. So, I wouldn't be too concerned. But we definitely would want to be proactive with recommendations for parents to prevent this child from becoming overweight. So what types of information should we give to parents?
Diet recommendations.
Mm-hmm. What else?
Activities for them to do to stay active.
Yeah, increasing activity, making sure that they're doing appropriate activity. They're not just sitting and watching TV all day. Good job.
Maybe like a set feeding schedule.
Yeah, looking at their feeding schedule. Absolutely. So we've got one more here. So this one, we have a 24-month-old girl who weighs 36 pounds. So drop your pin where you think she would be on the growth chart. 24 months old, 36 pounds. And then think about, are we over or underweight? What recommendations would we give to parents? Nursing interventions. Feel free to shout them out as you're dropping your pins.
I feel like maybe she'd be overweight or getting like,
Yeah, she's off the growth chart. So what do we want to tell parents if we have an overweight 2-year-old?
definitely like they said earlier, like diet and activities that they can do.
Mm-hmm. Yep.
Either that or healthier snacks.
Yes, this is where nutritional counseling really comes in handy, is what are parents feeding? Are we eating snacks and junk food? Or are we focused on nutrition and really getting the most out of what we're eating? Are they, terrible twos are often a time where parents will give snacks just to console their child. So is it, a child that is just being a 2-year-old and having a lot of temper tantrums and parents just give them a snack to keep them under control? Things like that are all things that we need to take into consideration. So like most of you guessed, we are way up here on our growth chart. So we're actually in the length portion instead of the weight portion. So we are definitely on the high side here. Okay, questions on growth charts? Do those make sense? And how we use them? Okay. Another thing that we use is the Denver Developmental Screening Tool. So this assesses a child's development, what we expect them to be able to do at a certain age. It looks at their personal skills, their social skills, their actual motor skills, and their language. So we use this to look for developmental delays and start early intervention. We do this routinely at doctor's appointments, prior to school, and then if we notice difficulties in school. So this gets done multiple times throughout the child's early development to help us know where they're at. This is not an intelligence test. We can't diagnose anything based off of the results of this. This is just a screening tool that identifies a child that is at risk for a delay. So we can't actually make any diagnosis from this. So here we have our first critical thinking question. We have a 6-year-old patient that's coming to the clinic for her annual physical exam. Her mother states she does not like to eat and she believes her child is underweight. She's concerned that the child will become ill if she doesn't eat. What assessments need to be done in order to determine the best course of action for the child? What do we think?
I would check height and weight, and then along with that, I would see if there's anything that she does like to eat, like if she likes carrots over broccoli or anything like that.
Absolutely. What else?
Would it be appropriate to do like a slight mental evaluation to see why a 6-year-old doesn't want to eat?
Yeah, we definitely need to find out if there's a reason. Lots of questions to answer. What other things could cause her to not want to eat?
If she's not feeling well,
Yeah, if she's not feeling well, she could have a physiological problem that makes her not want to eat. So how are we going to encourage parents and provide education to parents that are dealing with a child that doesn't want to eat? What do you guys
give
think?
them different food choices to choose from.
Yeah, focus on our favorite foods and see if you can get her to eat those. Yep.
And then maybe like when you do give them food, maybe like serve a smaller portion so it doesn't seem like overwhelming.
Yeah, it may just be a portion issue. Providing praise when she does eat, encouragement when she does eat, making sure that we're not punishing her for not wanting to eat certain things. Lots of things that go into nutrition and the psychology behind nutrition, especially with our pediatric patients. Great job, guys. Okay, we are going to move on to the next section. And I don't know that that changed. There we go. So we're going to look at factors that influence growth and development, looking at family-centered care, and start into our developmental theories. So we have lots of things that influence the growth and development of a child. Heredity, nationality, and race, their ordinal position in the family. So that's whether you're an only child or if you're a middle child, where you fall in the rank of your family, your gender and environment. All of those play into your growth and your development. We also have types of families. So depending, everyone's family structure can be different. We've got our nuclear family that is parents and biological children. We have extended family that includes aunts, uncles, grandparents. We know that we can have different types of families, single families or single parent families, foster families. We can have alternative families where it's not necessarily based on biology. We can have dual career parents. Sometimes we have a parent that stays home. We can have blended families when we're looking at divorce and remarriage. We can have polygamous families where they have multiple parents, homosexual families. We have cohabitation families as well, where we've got multiple families living in the same dwelling. So all of those can affect how a child progresses. When we're assessing our family, we look at the family APGAR. So adaptation is how the family helps and shares resources. Partnership is going to be lines of communication within the family. And then growth is how responsibilities for the growth and development of the child are shared among the family members. Affection is going to be overt and covert emotional interactions among the family members. Resolve is how time, money, and space are allocated to prevent and solve problems in the family. And all of those are going to give us an idea of how the family operates, what resources they have, and areas that we might need to provide support. Our first theorist is going to be Erik Erikson. And I am going to show you a short video here that looks at Erikson's stages of development.
Erikson's theory of psychosocial development identifies 8 stages which a healthy individual should pass through from birth to death. At each stage, we encounter different needs, ask new questions, and meet people who influence our behavior and learning. Stage 1. Basic trust versus mistrust. As infants, we ask ourselves if we can trust the world, and we wonder if it's safe. We learn that if we can trust someone now, we can also trust others in the future. If we experience fear, we develop doubt and mistrust. The key to our development is our mother. Stage 2. Autonomy versus shame and doubt. In our early childhood, we experience ourselves and discover our body. We ask, is it okay to be me? If we are allowed to discover ourselves, then we develop self-confidence. If we are not, we can develop shame and self-doubt. Both parents now play a major role. Stage 3. Initiative versus guilt. In preschool, we take initiative, try out new things, and learn basic principles like how round things roll. We ask, is it okay for me to do what I do? If we are encouraged, we can follow our interests. If we are held back or told that what we do is silly, we can develop guilt. We are now learning from the entire family. Stage 4. Industry versus inferiority. Now we discover our own interests and realize that we are different from others. We want to show that we can do things right. We ask if we can make it in this world. If we receive recognition from our teachers or peers, we become industrious, which is another word for hardworking. If we get too much negative feedback, we start to feel inferior and lose motivation. Our neighbors and schools now influence us the most. Stage 5. Identity versus role confusion. During adolescence, we learn that we have different social roles. We are friends, students, children, and citizens. Many experience an identity crisis. If our parents now allow us to go out and explore, we can find identity. If they push us to conform to their views, we can face role confusion and feel lost. Key to our learning are our peers and role models. Stage 6. Intimacy versus isolation.
We can skip
As
this
young
part.
adults, we slowly understand who we are, and we start to let go of the relationship.
There we go. We don't need to worry about the last stages because they don't apply to pediatrics. They apply to adults only. Questions on Erickson? Okay, next is going to be Piaget. So we also have a video for him.
Piaget's theory argues that we have to conquer 4 stages of cognitive development. First, the sensory motor stage. Second, the pre-operational stage. Third, the concrete operational stage. And fourth, the formal operational stage. Only once we have gone through all the stages, at what age can vary, we are able to reach full human intelligence. 1. The sensory motor stage, ages birth to 2. In the sensory motor stage, we develop through experiences and movement our 5 senses. Our brain wants to see, hear, smell, taste and touch as much as possible. First, we start with simple reflexes, and soon after we develop our first habits. From 4 months old, we become aware of things beyond our own body, and then as we get older, we learn to do things intentionally. A key milestone is the development of working memory, or in Piaget terms, our realization of object permanence. Before that, our mum can show and then hide a teddy, and we would think it's gone. After, we understand that objects continue to exist, even when we can't see them. We start becoming curious about everything. We want to smell flowers, taste food, listen to sounds, and talk to strangers. To explore more, we move. We learn to sit, crawl, stand, walk, and even to run. This increased physical mobility consequently leads to increased cognitive development. But we remain egocentric, meaning we can perceive the world only from our own point of view. 2. The pre-operational stage, ages 2 to 7. Our thinking is mainly categorized through symbolic functions and intuitive thoughts. We have lots of fantasies and believe objects are alive. As we are not able to apply specific cognitive operations, Piaget calls this stage pre-operational. We learn to speak and understand that words, images, and gestures are symbols for something else. When we draw our family, we are not concerned about drawing each person to scale, but rather with their symbolic meanings. We love to play pretend, which allows us to experience something new and learn a lot. At around age 4, most of us become very curious and ask many questions. We want to know everything. We can call it the birth of primitive reasoning. Piaget calls it the intuitive age, because while we realize that we have a vast amount of knowledge, we have no idea how we acquired it. Our thinking in this stage is still pretty egocentric. We think others see the world like we do, and still don't understand that they see it differently. 3. The concrete operational stage, ages 7 to 11. We finally discover logic, and we develop concrete cognitive operations, such as sorting objects in a certain order. One example of this is inductive reasoning, which means that if we see someone eating a cookie, we can draw a conclusion and then make a generalization. And we now get the concept of conservation. We understand that if we pour orange juice from a normal glass to a taller one, the amount stays the same. Our younger sister will pick the taller glass, thinking she gets more. By the same logic, we only now can understand that if 3 plus 5 equals 8, then 8 minus 3 must equal 5. Our brain learns to rearrange our thoughts, to classify and build concrete operational mental structures. For example, we now know that we can reverse an action by doing the opposite. Excited by our new mental abilities, we apply them in conversations, activities, when we learn to write, and in school. As a result, we get to know ourselves better. We begin to understand that our thoughts and feelings are unique and not necessarily those of others. That means that we learn to put ourselves in someone else's shoes. 4. The formal operational stage, age 12 plus. Once we become teenagers, we become formally operational. We now have the ability to think more rationally about abstract concepts and hypothetical events. Our advanced cognitive abilities allow us to understand abstract concepts such as success and failure, love and hate. We form a deeper understanding of our own identity and our morality. We now also think that we understand why people behave the way they behave, and as a result, can become more compassionate. Our brain can now do deductive reasoning, which means we can compare two statements and reach a logical generalization. Our new mental skills allow us to plan our life systematically and prioritize, and we can make assumptions about events that have no necessary relation to reality. We can now also philosophize and just think about thinking itself. Our new sense for our identity now also creates egocentric thoughts, and some start to see an imaginary audience watching them all the time. Piaget believed in lifelong learning, but insisted that the formal operational stage is the final stage of our cognitive development.
Okay, questions there with Piaget. Does that help break that down a little bit into what's going on each stage? Okay. Last one is going to be Kohlberg.
Lawrence Kohlberg's theory claims that our development of moral reasoning happens in 6 stages. The stages themselves are structured in 3 levels: pre-conventional, conventional, and post-conventional. To understand this better, imagine a conflict at school. There is a fight in the schoolyard. 2 ninth graders are beating up Tom. Those who watch the fight are at different stages of moral development. Let's see what they do and how they justify their behavior. At stage 1, we make moral judgments based on obedience and punishment. Finn's sense of good or bad is directly linked to whether he gets punished or not. Finn sees what is happening to his friend and wants to help, but he doesn't because he is afraid the teacher may punish him if he gets caught fighting. He asks himself, how can I avoid punishment? At stage 2, we are motivated by self-interest. Mary decides to intervene and help Tom. She knows that she might get punished, but she also knows that she could become a victim herself someday. If she helps Tom now, he might help her in the future. She is asking herself, what's in it for me? At stage 3, interpersonal accord and conformity guide our moral judgment. Betty sees the fight and wants to intervene, but when she realizes that all the others are just watching, she decides not to get involved. She wants others to see that she is a good girl who is conforming with the ethics of the community. She asks herself, what do others think of me? At stage 4, we value authority and want to maintain social order. When the teacher sees the group fighting, he immediately steps in and shouts, "Stop! Fighting at school is forbidden." He feels that, above all, it is important to follow the rules, otherwise chaos breaks out. He feels it is his duty to uphold the rules that sustain a functioning society. He asks himself, how can I maintain law and order? At stage 5, we understand rules as a social contract, as opposed to a strict order. Jessie, who watches from afar, is not sure how she feels about this. To her, rules make sense only if they serve the right purpose. Obviously, the school rules prohibit fighting, but maybe Tom deserves to finally learn his lesson. Just yesterday, he punched a young girl from grade 1. She asks herself, does a rule truly serve all members of the community? At stage 6, we are guided by universal ethical principles. All those involved now have to face the headmaster. He first explains the school rules and why they exist. He then clarifies that rules are valid only if they are grounded in justice. The commitment to justice carries with it an obligation to disobey unjust rules. The headmaster's highest moral principle is compassion. He believes that all people should learn to understand each other's viewpoints and that they don't feel alone with their feelings. He asks, what are the abstract ethical principles that serve my understandings of justice? At the pre-conventional level, Finn is driven by fear and Mary by self-interest. Both judge what is right or wrong by the direct consequences they expect for themselves and not by social norms. This form of reasoning is common among children. At the conventional level, Betty responds to peer pressure, and the teacher follows the rules. Their morality is centered around what society regards as right. At this level, the fairness of rules is seldom questioned. It is common to think like this during adolescence and adulthood. At the post-conventional level, Jessie knows that things are complicated because individuals may disobey rules inconsistent with their own morality. The headmaster follows a universal ethical idea, at complete disconnect with what society thinks or the rules say. To him, everything is solved through compassion. The right behavior, in his opinion, is therefore never a means to an end, but always an end in itself. Not every person reaches this level. The American psychologist Lawrence.
Okay, so that goes into a little more detail than what you guys need to know, but if I didn't give you all the backstory, then it wouldn't make sense. So all you guys are responsible for understanding is pre-conventional, conventional, and post-conventional. You don't need to know each of the individual stages. But like I said, if I didn't explain the backstory, then you wouldn't understand the different overall stages. Questions on Kohlberg, does that make sense? Like I said, those are heavily tested on your exam, and that is what students struggle with the most. So if you're struggling with those, please reach out to me and I can try and help get them straight for you. As we move on to parent education, there's lots of things that we have to help parents cope with and adjust with. So one of those things is challenges and disappointments. So we know that our kids aren't always going to meet our expectations. And a lot of times with interacting with them in the hospital, there are disappointments that come with illness. So we have this beautiful picture in our mind of how their childhood is going to go and everything is perfect. And then you get this illness that throws you a curveball. And you never want that for your child. So it creates this inner disappointment. So we need to help parents cope with that and teach their kids how to cope with that. We also need to help children deal with successes and failures, how to manage their emotions. And then teaching them the types of skills that they need at each different level of development and each age. When we're looking at nutritional heritage, this is where race and ethnicity can play a different role in a child's nutrition. So for some families, food isn't a priority. They might not have access to adequate nutrition, which can in turn lead to mental retardation, growth delays, developmental delays. We can start missing those milestones. So we need to know ahead of time things that are important to the patient regarding their family, their culture, how they feel about food, so that we can do things like modify meal trays if we need to. It gives us a better indication of what deficiencies they might have. It also allows us to provide culturally sensitive care and any additional information that might be needed. So if you have a vegetarian or vegan family, how do they meet those protein needs that the child has when they're developing and growing? We know that food is essential for growth. We need extra nutrients when we're recovering from illness. So if we're not getting a good diet to start with, and then we get sick and we have even further nutritional delays, it's going to delay our healing. We know that vitamins and minerals are essential to building our immune system, and we need to be well hydrated, especially if we have a fever. And then protein is going to provide that energy that we're looking for. So food is essential to growth, development, and healing. So why do we, when we're introducing solid foods during the first year of life, why do we introduce them slowly?
For the allergies.
Yeah, we need to be able to assess for allergies or food intolerances. When we're looking at the child's gut maturity, we know that before 5 months of age, they don't have enough pancreatic enzyme to be able to digest complex carbohydrates. So we need to make sure that the fats that they get before 5 months are going to be those simple carbohydrates and fats that they can actually digest and use. Also, we know that their liver doesn't mature until they're 2 years of age. So being able to break down things that are processed in the liver is ineffective when they're little. During their initial year of life, their central nervous system is developing. They've got that period of rapid growth and development. So they might need extra nutrition. We might have to supplement their oral intake with parenteral nutrition or through an NG tube so that we can give them those extra calories, those extra nutrients that they need during that critical period of growth. We know that childhood obesity is a growing problem in the United States. Why do you think the United States struggles with obesity?
Processed
Healthy
food.
foods. Oh, healthy
Processed
foods are more
foods.
expensive.
Yeah, yep. Absolutely. We rely a lot on fast food, processed food, convenience. Also, it's unfortunate that a lot of times healthy foods are marked up. They're just more expensive. So those are all things that could lead to obesity, things that we need to take into consideration when we're looking at the child's development. When we are sick, we know that our nutritional needs change. If we have a child that would have lesions in their mouth, how do you think that would change their nutrition?
They'll lose their appetite.
Yeah, they're not going to want to eat. If it hurts, they're not going to want to eat. So what do we do for them?
Figure out what they can eat and tolerate.
Yeah, we can give them soft foods. We can do good mouth care. We can also do numbing agents before they eat so that we give them a better chance of being able to tolerate their food. When we're looking at a child's hydration status, how do we tell that they're getting enough liquids?
You can look at the diapers if they have any, like a lot of like wet diapers. Also like maybe like their skin. Like I know sometimes skin integrity can let you know if they're dehydrated.
Yep, looking at their skin turgor, their urine output, vital signs. With our infants, we can look at their fontanelles too. If their fontanelle is sunken in, those soft spots on their head, if it's sunken, it means they're dehydrated. If it's bulging, then it means that we might have an overhydration issue. So lots of ways that we can assess the child's nutrition. What do we need to teach parents when we're talking about feeding our younger children? So our infants, toddlers, preschoolers, what are important things for them to know?
Make sure that they're sitting upright.
Yep, they should be upright. What else? Especially our little kids as they're learning how to eat finger foods. What's important?
Making sure things are cut up small enough, not a choking hazard.
Yep, choking guidelines. Parents need to know that. The other thing that's really important is their stomach size. expect a infant or a preschooler to, maybe a preschooler, eat 3 square meals a day? No, they eat more often. So their stomach size is substantially smaller than an adult. The guideline that we give for stomach size for pediatric patients, for our infants and our toddlers, is going to be 1 tablespoon of food for each year of age. So for a 2-year-old, we really expect them to eat like 2 tablespoons of food, and that will be enough to keep them going. So remembering that their stomach size is really, really small, and we really need to maximize their nutrition because they don't have that capacity. We also need to be aware of interactions between foods, medications, environment. So a food-drug interaction is going to be cranberry juice, pomegranate juice, blueberry juice. All of those are going to contain flavonoids that are going to interfere with the absorption of drugs like ibuprofen, phenytoin, or fluvastatin. So we've got foods that we can't eat when we're on certain medications because it's going to interfere. You don't need to remember those specifics, just the fact that we need to keep an eye out for foods and certain medications. Also, when we are giving medications to infants, when they're bottle feeding, how should we give those?
Syringe.
Yeah, a syringe with a pacifier is going to be your best method. That way you can know exactly how much of the medication that they got. If you mix it in with their formula or their breast milk, you can either have a potential interaction with something in the formula or the breast milk. Also, it could make the taste different, and they might refuse to eat altogether, and then you've lost your medication, and also wasted your feeding. So giving it in a syringe is going to be your best method. Another thing that we need to watch out for is those interactions with the environment. So things like antibiotics that are photosensitive, we can't have them out in the open. It also can cause a child to be sunburned easily if it's a medication that has photosensitivity. So what are some cultural food influences that affect a child's intake? And what education do we need to provide parents? So how can culture influence a child's nutrition? You guys can shout them out, type them in, either one.
Did you say that we can shout them out?
Yeah, if it's easier to just shout them out, you can do that too.
I was thinking maybe like if a child grew up in like a Jewish household, you know, they have a kosher diet.
Yep. Yeah, there's certain things, certain things go against their cultural practices. So we might have to modify things. What else?
When and how they eat.
Yeah, sometimes, different cultures have different beliefs on food. Sometimes they will observe periods where they're fasting. So is that a child that's in a period of fasting? How do we make sure that they're getting enough nutrients when they're not eating during normal times? Vegan or vegetarian? Yep. Finding out how to get them the protein that they need for growth and development and healing. All of those are going to influence our child's nutrition related to culture. We're going to go ahead and move on. We've got a critical thinking question here. So we've got a 9-year-old boy is the second of 3 children. His parents are divorced and he sees his father once a month. He is often in trouble with his teachers not getting along with his classmates, and below average grades. How would you apply those theories that we learned about to this child? So according to,
right?
go ahead.
He's a middle child. He's a second child, second of three
Yep.
children.
Yep.
Well, the middle child always.
Yep, sometimes the middle child can act out, yes.
I think due to his parents being divorced and the changing environment causing him to misbehave in school.
Yeah, we've got to take into consideration the changing environment. Are the rules the same with mom as they are with dad? Do we have consistency? Do we have the same schedule? All of those are going to impact his behavior. So if we're looking at Erickson, what stage is this child in if he's 9?
Industry versus inferiority.
Yep, industry versus inferiority. So he might be having school issues because of the parents being divorced, only seeing his father once a month, not properly learning how to relate to his own sex. So not having that father figure consistently might be impacting his development. Might not have good coping skills because of the social environment. We didn't really talk about Freud, but he would be in the latency period according to Freud. So that's where he's going to be learning to live in groups, and having those 2 separate households is going to kind of disrupt that learning. Where are we at according to Piaget? So Piaget was all about cognition.
Is that the concrete operations?
Yep, we're concrete operations. So logical, systematic thinking that's limited to your own experiences. So he's not going to be able to have that abstract thought. He's going to have trouble relating to peers. And we might see that he's kind of hanging on to that egocentrism that he should be losing at this point. Does that help you be able to apply the different theorists to a scenario? Okay. Okay, moving on. So we're briefly going to talk about our teeth. There's some important things to remember when we're looking at our teeth. So our teeth are starting to come in, but we know that we're going to lose them at some point. What is bottle mouth? Who's heard of that? Or nursing caries?
They get it from like breast milk sometimes, or like milk, like when you let them have like baby milk before they go to bed sometimes.
Absolutely. So putting an infant to bed with either a bottle or juice can cause tooth decay because those sugars just sit on the teeth all night and cause them to rot. Why is it important for our permanent teeth to develop in alignment? Why is that so important?
It can affect the way that we eat.
Yeah, we might not be able to eat. Also causes a lot of jaw pain. So if our teeth don't develop in alignment, then we might have issues with being able to eat appropriately. So when we're teaching parents about tooth care, we want to have them just wipe the infant's gums after they're about 2 months of age with a moist cloth, and then they'll start brushing with a gentle, soft toothbrush once that first tooth erupts. So as soon as they have a tooth, then we start brushing it. We don't start fluoride toothpaste until they're 1 to 2 years of age. And we only use about the size of a grain of rice. So very small amount of toothpaste. And making sure that we're not putting a child to bed with a bottle. If they need a bottle to go to bed, it should only have water in it. So our balanced diet is going to influence the health of our teeth as well as our jaw development. And then if we have a high sugar diet, it's obviously going to increase our risk for tooth decay. And we talked about brushing teeth as soon as that first tooth comes through. if we have these consistent nursing carries, that tooth decay can cause dental abscesses, which can result in serious complications and having to be surgically corrected. So some of the things that we can tell parents that are catchy is read, don't feed, meaning we read them a story instead of giving them a bottle at bedtime to help with that bedtime routine. And then making sure that we're only using water in a bottle at bedtime and appropriate oral care. We want to make sure that we replace our toothbrush every 3 months so that we don't get that bristle breakdown and we decrease our level of bacteria. And then we want to make sure that we're not using closed containers to store our toothbrushes because that's going to be just the perfect breeding ground for bacteria. Why should we tell parents not to taste their baby's food before feeding it to them? Like using the same spoon?
I would say bacteria.
Absolutely. So the bacteria from your mouth can get transferred to the child, and we know that they have an immature immune system, and that puts them at increased risk for exposure. Did you guys have questions that I didn't answer? Okay. When we're looking at play, play is going to be the work of children. So they are going to learn new skills. They are going to explore their environment all through play. So that is their focus. When we're looking at appropriate play for children, we also need to make sure that we're matching their toys with their condition. So we want to make sure that a child with asthma doesn't get a stuffed animal that can have dirt and dander in it that would exacerbate their condition. Also, if we've got a kid in a spica cast or immobilized in traction, we don't want to give them active activities that would require them to get out of bed because they're just not capable of that. So it's really important that we are giving an age appropriate activity as well as a condition appropriate activity, making sure that we're encouraging the development of those developmental milestones, making sure that we're meeting their needs both mentally and physically. Our next critical thinking question, we've got an assessment on a 2-year-old. We've got numerous nursing carries in the child's mouth. What kinds of recommendations and teaching are we going to give to the parents? And what dangers are we going to warn them of?
Well, we want to teach them like about like dental hygiene, like why it's important for them to brush their teeth. And definitely, like you said earlier, I think you said something about it causing like abscess in their mouth.
Yep, absolutely. What else?
Brushing every night before bedtime.
Mm-hmm.
Teaching them the cause of why it happened and advising them not to put the child to bed with a bottle.
Yeah. Yep. If you have to go to bed with a bottle, it should only have water in it. Yep. Good job, guys. Okay, now we're going to focus on our infant specifically. So we've got these developmental milestones that we keep talking about. So when we're looking at our infants, we first want to look at their normal sleep-wake cycle. So for an infant, we expect them to sleep about 20 hours a day. They wake up to eat every 2 to 4 hours, and then they go right back to sleep pretty much. They should be sleeping throughout the night by 4 to 6 months is what we typically expect. We expect that social smile at about 2 months, and then they should start drinking from a cup at 10 months. And then we have separation anxiety. So this is when we have those big meltdowns when parents leave. It begins at 6 months and peaks at 10 months. So that is something that we're going to look at in detail later on as we look at hospitalizations and the effects that it has on kids. But it's important to remember that we peak at 6 months, or we begin at 6 months and peak at 10. So this or that, which is the normal heart rate for a 1-year-old child? So pick which one is normal.
Oh. I don't know. 100 to 160 is an infant.
There we go. So 100 to 160 is going to be a normal newborn heart rate. Our 1 month to 11 months is going to be 100 to 150. So right in that same range. We want to think of the heart muscle like a rubber band. The further you stretch a rubber band, the harder and more forcefully it's going to snap back into place. So if an infant's heart can't stretch very much because it's immature, it has to pump a lot faster to maintain our blood flow. So as a result, we're going to have a higher heart rate. Can also be very irregular and easily affected by a child crying or their body temperature. So if they're crying, they're going to have an elevated heart rate. If they're cold, their heart rate's going to drop. So what about our respiratory rate? Just a ballpark. So for our newborns, we're going to expect them to be 30 to 60 breaths a minute. And then our 1 month to 1 year old, they're going to be 25 to 35. Having a higher respiratory rate is going to give them a higher metabolic demand, or they have a higher metabolic rate. Therefore, they're going to have a higher respiratory rate and they're going to consume more oxygen. The higher the respiratory rate is, the greater loss of water from their lungs. Again, your respiratory rate is easily going to be affected by crying. What about blood pressure? By 1 year of age, what is the normal blood pressure? Yep, 90/60 by our first year. So this is going to be impacted by our systemic vascular resistance and our absolute blood volume. So we know that we don't have as much blood volume because we are much smaller in size. Also, we don't have that vascular resistance. So we're going to have a lower blood pressure than an adult. Oxygen saturations, what do we expect for our kiddos?
Oh, that's greater than 90.
Yep, we want our kids to be greater than 90 when they're just on room air. So we're a little bit more tolerant of lower saturations than we are with adults, just because we've got that immature lung development. When we're looking at our infants, they're going to be in the oral stage. So they are going to relieve tension and explore their environment through their mouth and through sucking. That sucking skill will allow them to develop the oral skills that they need for feeding. And that's why non-nutritive sucking is going to be so important for them. They're going to use it for pleasure and for comfort more than nutrition, but it's also going to develop those skills that they need. So this is when we're giving them a pacifier or they're sucking on their fingers. That's that non-nutritive sucking. The grasp reflex is when you place your finger inside of an infant's hand, they're automatically going to grab it. So anytime you touch their palm, it's automatically going to grab. We teach parents that that's a great way for bonding. So letting the infant hold your hand assesses that reflex and promotes bonding between the mother and the child. Prehension is going to be the ability to grasp objects between the fingers and the opposing thumb. So kind of that pincer reflex. And then the parachute reflex is like that middle picture that's shown there. If you hold a child by their hips, and move them forward like they're gonna fall, then they should stretch out their arms and their legs to brace themselves. We talked about the pincer already. We also have to assess emotional development. So if we are looking at a parent and a child interaction, we need to give them time to be ready for tasks. So we know that everything with our infants are immature, so we need to give them time to adjust before we move on. So it's important that when we're doing things with them, that we're slow when we integrate sound, that we come in quietly. We don't suddenly startle them with loud noises. We need to ease into handling and watch for their cues as we're interacting with them. So are they getting agitated? Are they getting overwhelmed? And how do we think a sense of trust promotes our emotional development?
What did you?
How does trust promote emotional development?
Oh, if a kid can trust an adult, they will grow up not with their guard up all the time, I guess.
Yeah, it's as simple as having our needs met. So an infant getting food when they cry or being picked up when they cry, having those basic human needs. So following that Maslow's hierarchy. Also with Erickson, we know if we don't develop trust, then we struggle to progress through our development. We need to make sure that we're providing appropriate sensory stimulation, making sure that we're working through those developmental milestones, making sure that we're soothing a child when they cry. So we're developing that trusting relationship. If they're hungry, we feed them, even if it's off schedule. So we do need to be flexible with our interventions and providing for those needs. So we have a 26-year-old that brings in her 3-week-old son for a follow-up visit. She expresses concern about holding the baby too much when he cries. She's afraid she's spoiling him. What do we tell the mother about the infant's emotional development?
She's not spoiling the baby. It's helping the baby to develop trust in when he needs something that the mother or the parent's going to be there.
Absolutely. What do we think this is going to do long term?
It might cause dependence long term.
It can, but if she's only doing it when the child's crying, is that going to promote that trust?
No.
Yeah, so if we're crying and we're expressing a need and it's being met, we will be developing that trust. Also, if kids are consistently picked up when they're crying, they tend to show less aggressive behavior during their toddler years. And it can be helpful to communicate with the baby as well through talking, singing, and touch to develop that trusting relationship. Okay, this would be a great time to take a quick break if you guys need to go to the bathroom or get a drink or anything. As soon as you guys can be back, and that way we can get through the rest of our content because we do have a lot to cover today. But feel free to jump off real quick, go to the bathroom, get a drink.
What time we need to be back?
If you guys can be back in at least the next 10 minutes, that would be great.
Okay.
I'll link up with you. I got it with you. I'll catch up with you.
Okay, so listen, I already know. Because I feel like that. So, I've never seen one like this, but it's just like that extra. I feel like the biggest one or the biggest one. You add that, whatever answer you get, you multiply that by 250. So that's it. You know what I'm saying? This is wrong. You see this one? Let me sit down. It's close. Let me look at it. Okay, you should have 8. Go ahead. Oh, no, it's not. Feel like a lot of rice. Over that. What's today? The 8th. It just looked like the whole.
So anytime I got this like this, I will put 10 over X.
So with this one you do.
Okay, it looks like most of us are back. Wonderful. So we will go ahead and continue on since most of us are back now. So when we're looking at irritable and lethargic infants and how to cope with them, we can use a lot of the same interventions. So when we've got an irritable baby, they're going to be crying, they're going to be inconsolable, whereas a lethargic baby is going to shut down to avoid that excessive stimulation. So either way, we are going to try and shield their eyes from any bright lights. We're going to position them in a comfort position. So you can see some different examples of comfort positions. The bottom right picture is the colic carry. So that is really helpful for infants with colic, just helping them to settle down and deal with that stomach discomfort. So either if we've got an irritable infant, we want to sit quietly with them. We don't want to be talking or singing. We want to eliminate that overstimulation. So no noise. If we talk in a soft voice. We want to swaddle them real tight and then change their position slowly. So making sure that we're, when we're laying them down, we're going slow. If we're sitting up, that we're going slow, just so that we're not creating that quick stimulation. Also providing non-nutritive sucking. Remember, our infants soothe through that oral sensation. Our lethargic infants are going to be the same. We're going to avoid those bright lights, handle them slowly and gently, talk in a calm voice. With our lethargic infants, we do want to change their position periodically so that we're giving them a little bit of stimulation. So we want to sit them upright at intervals to provide just a little bit of stimulation, but not too much. And then making sure that we're slow when we dress and undress them. So what would be an example of a reason that an infant might be lethargic and shut down? What can cause a lethargic infant?
No oxygen, like maybe they can't breathe or something.
Mm-hmm.
Would jaundice make a baby lethargic?
It can if the levels are really, really high. I'm thinking real general terms here.
Dehydration.
Dehydration, low blood sugar, kind of go hand in hand there. Infection is also another big one that can cause your infant to be lethargic. And like we talked about, also overstimulation. So an infant can get to a point where they're so stimulated that they just can't take it anymore and they completely shut down. So those are all things to keep in mind if you're seeing a lethargic infant. When we're looking at sleep patterns, we need to teach the parents how to help the infant self-soothe. So we know that if their needs are met, they have a consistent schedule. We can do things like white noise and offering a pacifier. Those are all ways that the infant can self-soothe. And if we're teaching the infant how to put themselves back to sleep, it will help to ease that transition for parents and help that normal circadian rhythm, getting them back to sleep on their own, all very important. When we're looking at illness prevention and parent education, we know that we have lots of well baby checks that are required. So we know that we recommend them going to the pediatrician at least 5 times during their first year of life. So typically at 2, 4, 6, and 9 months, and then they'll have a 1-year checkup. Vaccinations are encouraged in the US to prevent the spread of preventable disease. What are some things that we would give anticipatory guidance to parents? So teaching them ahead of time. When we're doing that parent education.
Like hand washing, like something like that, you mean?
This is more so like guidelines of what to expect with their child.
You may expect like a low fever after they get shot.
Yep, that's important for them to know.
Changing urine output.
Mm-hmm.
They're probably not gonna want to eat as much.
Yep. Some other things that we would give anticipatory guidance, we want to teach them about new skills that the child's going to develop and how to encourage the development of their skills. Like, what do we expect them to be doing? And then what's the next stage? So that parents can be aware and start thinking about how they're going to work with their child, interact with their child, making sure that we're meeting those progressions. Skincare is also going to be important for our parents, knowing that we've got that immature skin, so it's going to be more sensitive. So heat, cold is going to have a stronger reaction. Also, we're going to burn a lot easier because we've got that thin skin layer. We're also at risk for things like diaper rash, and how do we prevent that? What are things that we use for diaper rash?
I know you can use like Destin cream, like stuff like that, like butt paste. I know people use.
Yep, barrier creams, exposing the child's bottom to air, get that oxygen in there. Also changing their diapers frequently. So that's another thing that's important for diaper rash, making sure that they're not sitting in a wet or soiled diaper. When we're assessing an infant, then we're going to assess for their nutritional status. So we're going to look at their growth, their development, what they're eating. We're also going to do hearing and vision assessments. We'll do our screening test, like our newborn screen, where we do that metabolic panel. How do we determine that an infant is receiving adequate nutrition when mom's breastfeeding?
It'd be the diapers.
Yep. What else can we do? If we've got them in the office.
Weights.
Oh, wait.
Yep, we can do weights. Obviously, we're gonna plot them each time that they come in and make sure that they're following on the growth chart. We can also do pre and post feed weights. So we can weigh them before, let them eat, weigh them after, see what the difference is to get a ballpark idea of how much they took. All good ways to help assess the nutrition status when we're breastfeeding. We can also look at the fontanelles. Remember, those soft spots are a good indication of whether or not we are having good nutrition. When we have infants with special needs, then we want to get them connected with early intervention to get those best outcomes. So the earlier we intervene, the easier it is for them to catch up and meet those milestones. So we might need community referrals, we might need therapies like speech, cognitive therapy, neurodevelopmental therapy, physical therapy. All those things can be really, really helpful in getting a child back on track. We need to stress the importance of immunizations and sticking to the schedule. Delays in starting immunizations can lead to an increased risk of illness or even death. And then we also need to stress the importance of accurate record keeping so that we prevent confusion or duplication of immunizations if a child's moving from different offices. So keeping track of what we've gotten and staying on schedule. When we're talking to parents about nutrition for infants, we're going to start adding solid food at 6 months of age. And we're going to start with rice cereal because it has a low risk of allergies. At 3 to 4 months of age, the child should lose their extrusion reflex, which is where as soon as you put food on their tongue, they're going to push it out of their mouth. So the whole point of this reflex is to prevent the child from aspirating and food. So by 3 to 4 months, they should be able to start receiving food into their mouth and be able to swallow when appropriate. Between 4 and 6 months, we begin to see chewing and chomping motions along with that mature sucking pattern. And that's going to indicate that we are ready for solid food. Does anybody know why we start introducing solid food at that 6-month age? So at this point, at 6 months, we expect that their GI system is going to be more developed. Also, our formulas are no longer going to provide the appropriate nutrition for the child. So at 6 months of age, we start to see mom's iron stores be completely exhausted. And so we're going to need to supplement those. So we're going to start with adding solid foods, providing that increased nutrition, more opportunities for those minerals and vitamins to be introduced to the child. So when we're looking at infant food preparation, we've got either truth or lies in the statement. So which of these do you think are true and which do you think are false? We got some votes in. Okay, so here are your answers. We want to make sure that we're only thawing enough food for a single serving. We want to cook foods until they're tender and avoid overcooking so that we're not destroying nutrients. We don't want to add salt in any way because we are at risk for hypernatremia at that point. And then we only use sugar sparingly. And then we want to make sure that we don't give honey until they're at least a year old because of the risk of botulism. So all things that we need to keep in mind when we are preparing infant food. When we're looking at the adequacy of diet, we want to see that consistent weight gain for the first 6 months. We also want to make sure they have at least 6 wet diapers a day and that they're able to sleep for several hours after they eat. Those are all signs that they're getting appropriate nutrition. We want to promote breast milk for the first 6 months because we've got the immunity that is passed through breast milk. Also, iron is better absorbed through breast milk than it is through formula. And then we want to make sure that we don't introduce cow's milk, whole cow's milk, until after the first year of age, because it's very high in protein and minerals that can cause intestinal bleeding. So that's why we wait until later on before we're introducing whole milk. We try to encourage breastfeeding as often as possible, but there are certain situations like the ones that are listed here that require formula feeding. So we try and encourage it, but there are contraindications to breastfeeding. We have prebiotics and probiotics. So prebiotics are going to be foods, typically high fiber foods, that act as food for the human microflora. So your bacteria in your gut. So those are going to make sure that we get that good balance of good and bad bacteria. Probiotics are foods or supplements that have live microorganisms that are taken to improve the good bacteria. So your probiotics promote good bacteria. We can use those for diarrhea or protective for the GI tract. We are going to go ahead and skip this question so that we can get through more content. When we're looking at bottle feeding, we need to make sure that our formula is not expired. We're following the instructions on how to mix it, store it, and feed, always using clean containers, never heating in a microwave, and then making sure that if there's formula left over from a feeding that we throw it out. So if we refeed old formula, the bacteria from the mouth can grow inside of the milk and cause diarrhea. So that's why we don't want to continue using the same formula over and over again. Why do we want to avoid introducing new foods when an infant is sick?
It can mask the
We might not see
Allergies.
reactions. Like we talked about, rice cereal is going to be low allergen, so it's going to be our food of choice for their first food. And then why don't we want to mix formula with cereal or food in a bottle?
They can choke.
Yep, they could choke. What about actually like getting it out? If we're putting food plus formula,
Too thick.
yeah, it's going to be too thick to get it actually out of the bottle. So they're going to be working and getting nowhere. So that's why we keep them separate. Infants are going to need more calories than toddlers, preschoolers, and school-age kids because they're in that rapid growth period and development. And fats are going to be essential because they have that really small stomach capacity and that big caloric need. So easily digestible fats are going to be key. And those are going to be needed for their brain development. So full fat is really important under 2 years of age for that brain development. We expect kids to start feeding solid foods between 4 and 6 months of age because they've got that mature suck, they've got that munching motion. When we're weaning, it's important to remember that we don't start weaning until we've begun to introduce solid foods. So we're gonna begin the weaning process at 5 to 6 months when we're introducing those solid foods. And that's gonna continue until the child's about 2 years old. So it's a very long, drawn out process. So we're gonna balance weaning off of formula or breast milk with continuing to meet the child's nutritional needs with those solid foods. So it's an ongoing process, but we have to keep them balanced. When we're looking at organic and natural foods, those are ones that don't have any additives. They've got extra guidelines and regulations on them. Nutritional value has not been shown by research to be superior to non-organic foods. So it's really important that parents are just reading the food labels and being aware of what's in the food. When we're providing recommendations for increasing the solid food intake, we want to make sure that we're giving our solid foods before we're giving milk, so that the infant is willing to try those foods and they're not full from getting their milk first. If our milk or formula feedings decrease as our solid foods increase, how are we going to monitor our nutrition status? So as we're weaning off of our milk and increasing our solid foods, what are we looking at?
Wet diapers.
Looking at those wet diapers, monitoring their growth, whether they're satisfied after a feed, can they sleep, can they do their normal activity, also assessing their skin turgor and fontanelles. Remember, only small amounts of food. Remember, they have that really small stomach size. Also, we want to put food on the back of their tongue so they don't just push it out immediately. And starting with those very simple foods. When we're looking at infant safety, we need to pay attention to our car seats. So we should be rear facing for kids that are under 2 or within the maximum weight of the seat. So about 30 pounds. They should be rear facing until then. But always go by the seat guidelines. For fall prevention, remember they never leave an infant unattended on a flat surface. Make sure your side rails are up. Making sure that we have gates for stairways and pools. Looking at toys, we need to assess whether or not it's appropriate for their development, making sure there's nothing that they can swallow or pull off and swallow. And then looking at how they respond to the toy to determine whether or not they might be ready for a new skill. So we know the typical toy safety guidelines. Anything that can fit through a toilet paper roll is going to be a swallowing hazard. So making sure that it's not a swallowing hazard, making sure that it's appropriate for their development. For household environment safety things, we're looking at outlet covers, gates, fall prevention, making sure that we have locks on our cabinets so that they can't ingest poisons. And this is just going to be a summary of our development changes in the first year. So this is a good snapshot of kind of what we expect during the first year. And we are going to skip that question. We've got one more. Actually, I can just go back here. We have part 2 here. Looking at our toddlers. Okay, so looking at our toddlers. Make sure that's right. Yep. Okay. We're talking between our 1 to 3 year olds. They're going to be in Erickson's stage of Autonomy versus shame and doubt. If we've got a lack of trust, then we're going to have difficulty moving into doing things independently. During this time, we expect parents to be responsible for maintaining a safe environment while allowing their child to be independent. We need to maintain a positive self-image and body image for the child. When we have negativism, that can be countered by offering limited choices and the use of distraction for toddlers that are constantly saying no to everything. If we're trying to distract a toddler, we might give them an opportunity to do something else, focus on something that they enjoy doing. Those are all ways to get a child distracted. And then we're looking at developing socialization, self-control, learning how to manage our emotions, appropriate interactions with people, how to express anger. And this is where we see ritualism be really important to a toddler. So they're looking for that sense of security by constantly knowing what to expect. So ritualism is having that set routine where they know what to expect, and that gives them a sense of security by knowing what comes next. So what are some of those rituals that toddlers have? Anybody?
Reading schedule for bedtime.
Yep, their bedtime routine. If they go to daycare or not, you know, are they out of the house during the day? Are they home with mom or dad all day? Bedtime routines, meal routines, all of those will give that sense of security. When we're looking at their physical development, we know that their growing is going to start to slow down a little bit. Their body proportions are going to change. We're going to start looking at things like toilet training. So much of that is going to depend on the temperament of the child and the person responsible for raising them. We need to make sure that the child's ready before we start toilet training. And remember that they don't have voluntary control of their anal and urethral sphincters until they're 18 to 24 months. So starting toilet training before that isn't going to be effective because they just don't physically have the capability. We know that our toddlers still have abdominal breathing, but we're going to start to see that shift into the thoracic cavity as they're getting into their school age. We know that they're able to maintain their own body temperature. They should have all of their baby teeth by 2.5 years. They're going to become more immune to infections. Their skin's going to be more developed. They're going to move to that 3-meal-a-day schedule. All of those are expected during this time. Our 2-year-olds are going to have synchronized sensory and motor functions. So their eyes are going to lead their actions. So what they see, they're going to reach for so that they can smell it, so that they can taste it, so that they can look at all the different characteristics of it. So their senses are going to help with their motor function. They're going to do a lot of trial and error to learn things. So you might see them repeatedly trying to put a block to match a shape. They're going to be able to tolerate longer periods of separation from their parents. They're going to be aware of cause and effect. So if I push this, then it's going to roll across the floor. Starting that logical thought process. Also, if their toys are stored in like a toy box, they're going to open every box that they see thinking that their toys are there. So it's that cause and effect. we're going to see a lot of copycat behavior. So they're going to model the words that they're hearing. They're going to model the behaviors that they see. So if I am a little boy and I see daddy doing yard work, then I'm going to want to do yard work with daddy because that's what daddy does. So we're going to see a lot of role behaviors learned from parents and what they see. We also see that they confuse essential with non-essential body parts. So if they go to the bathroom and they poop and they see the poop flush down the toilet, that might be upsetting to them because they think of that as part of their body being flushed down the toilet. They don't have the cognitive understanding that that's okay, that part of them is not dying. So that's something that we need to prepare parents for because that can be very traumatizing and very unexpected for parents. We need to encourage parents to promote that loving atmosphere, even if the child's behavior is unacceptable. So this is a difficult time for parents learning how to implement discipline without hurting the self-esteem of the child. So let's rank the attributes and give examples of how they apply. So what is going to be most important for toilet training? What's going to be least important for toilet training when we're looking at their skills? And then what are some of these skills?
I feel like language is important. Like it's not the most important, but it is important so they can communicate when they have to go to the bathroom.
Absolutely. What else?
Maybe this will go under social, but like patience with the child.
Yeah. Being patient with the whole process. We know toilet training is a very difficult process. What about our motor skills?
Maybe
I think-
doing, oh, sorry.
Oh no, you're fine. You can go. You go first.
I was just gonna say maybe like, what do you call that? Like a role model kind of like doing as I say, like
Yep.
watch, you doing it first and maybe having them, showing them how to do it.
Yep. We see that a lot with toilet training. Mom and dad are in the bathroom, so I want to try and go potty too, because I want to be big like mom and dad. Yep. Can we actually take our clothes off by ourselves to be able to go to the bathroom? Those motor skills come in handy there. What about cognition? What do they need to understand in order to be successful?
When they feel the urge to go.
We've got to understand those urges and knowing when we've waited too long or when we have to go. Those are all things that are going to come into play with toilet training. What about with self-feeding? So being able to feed ourselves. What are we looking at for social skills? Our family environment. Like, do we all sit down and eat a meal at the same time? Do we all do our own thing? What about motor skills?
Can they pick up the spoon, fork to feed themselves or the sandwich, whatever?
Yep. What about language? How important is language going to be?
I think it's really important. They got to tell you if they're hungry. I mean, as parents, we know if they are hungry, but some kids cannot communicate that they're hungry. They know they're hungry, but they don't, can't communicate it.
Yep. Yeah. Communicating when I'm hungry, communicating when I'm full, what I like, what I don't like. What about cognition for self-feeding? Understanding how to get the spoon to your mouth, those types of things. Dressing ourselves. What is this going to be heavy in?
Motor skills.
Yep, motor skills. A lot of motor skills go into being able to dress oneself. Also language, communicating when we need help with things or what layers if there's something that we want to wear specifically. Speech. What impacts our speech?
If you're taught how to talk.
Yep, your interactions. Absolutely. There we go. Yeah, obviously language is going to be important here. Yep, not so much our motor skills. There's some with just being able to move our facial muscles, but a lot of social language cognition go into speech development. How about satisfying curiosity?
I would say language.
Asking a lot of questions.
Yeah.
Yes, we know toddlers love to ask questions. Yep. This is going to be a little bit of everything. So we're going to have these thought processes going on that make us want to explore the environment. We're going to use our motor skills to be able to interact with those things that we're questioning, asking all those questions, understanding what's happening. So this goes across the board. All of them are going to be important. We're going to keep going. Our speech development. We know that our speech is going to parallel our cognitive growth. By 3 years, we're going to expect our child to have an extensive vocabulary, and we should be able to understand about 90% of what they're saying. They also have receptive language. So if they hear a sound, they're going to look towards it. They should be able to identify body parts, and they should be able to follow commands. When we're screening for autism, we're going to be looking at those developmental milestones, the parent-child relationship, and providing education and support there. When we're dealing with a child that is on the autism spectrum, we want to make sure that we have a slow-paced approach to them. We want as few distractions as humanly possible. We need to give them time to become acquainted with everything in the office, the people, the sounds, the equipment. We always ask permission before we touch the child, and we want to avoid any sudden movements or loud noises. Safety and family support are going to be the priorities here. When we're talking about guidance and discipline with parents, we really want to focus on teaching moments rather than punishment. We're looking for that guidance. A parent's response to a behavior is going to be either reinforce the behavior or deter that behavior. So making sure that we're keeping our emotions and reactions in check with what we expect. Setting reasonable limits, making sure that those are known, and then making sure that the punishment is matching. So for timeouts, we want to use 1 minute for 1 year of age as our guideline when we're looking at methods of punishment. We want to avoid physical punishment because we can cause fear, and that fear-evoking event, if that happens repeatedly, it's going to cause the child to not want to try new things. When we're looking at daily care, we want to make sure that we're at the child's level when we're talking to them because it's going to be less overwhelming. We need to have a flexible schedule, making sure that we can put our clothes on and off easily, making sure that we're doing sunburn protection. We talked about toilet training. Our nutritional needs are going to be changing. They're going to need protein for energy and growth, so we're going to start cutting back on our milk. Increasing our solid foods so that we build up our iron again. And then if a child is well nourished, they're going to show steady weight gain and height. Picky eaters are different than those with eating disorders. If they have an eating disorder, they're going to refuse food before 6 years of age. We need to make sure they don't have a GI issue that's causing the eating disorder. Daycare a lot is going to be personal preference. Making sure the important thing is that your daycare facility is state approved. Injury prevention is extremely important. Our toddlers are very curious and mobile, so they will reach and grab for everything that they're not supposed to. And then we have federal guidelines for consumer products that are going to be important, and toddler proofing homes. So making sure that they've got those safety precautions in place. We want to make sure that our toys are appropriate for their age, making sure it provides the right stimulation and socialization and allows them to explore the world. This is where we see parallel play start to develop, where they're playing alongside of a child instead of with a child. And that is it. So that is a ton of information. Feel free to go through the PowerPoints. I will link our recording today.